at any rate, a state-of-the-art event review team, a care for the caregiver team, and then this patient-family communication team, which is what we will focus on today. And you know, there's these best practices that fit in these various buckets related to the systematic approach to harm that include activating your system, the whole communication piece. And then, of course, as you review events, you share more. As you review more, you share more until ultimately you get to the position to where you're able to resolve these cases, at least financially, in situations where you deem care is inappropriate. But before getting at that, today we really want to focus on the communication component, where we move from delay, deny, and defend to immediate and ongoing communication. With the goal being sort of creating this cascade of candor kindness, where instead of a wall of silence, we are reaching out to patients, families, their loved ones, as well as the clinicians who may have been involved in these events, who also need peer support and support in having these conversations. And communication is central to this paradigm shift. And again, what our focus is going to be on today. And you know, we have to keep in mind that communication after harm requires a very high level of skill, because these situations can be very hard. They have multiple conflicting goals, where on the one hand, you want to be open and honest and transparent, and on the other hand, you want to not ring the bell. The bell's not ready to be rung. You don't want to speculate and set false expectations. And there's often a high level of emotional arousal, and you're going to see that today in some of the cases that we're going to go through, for which I have some videos to share with everybody. And of course, there's the high ego involvement, wanting to save face. You know, it's one thing to give a very difficult diagnosis to a patient or family, but imagine it's even harder to be able to give them very bad news that may be related to harm associated to a mistake that we made. And so that adds to the complexity of it. And these are very highly consequential conversations for both sides in terms of what it is that we're beginning to approach to do that. And what we've learned a lot, and I learned a lot of this from Tom Gallagher many years ago, that when we look at sort of the root causes of why communication doesn't necessarily go as well as we'd like, planning is often one of the keys. And so today we're going to talk a little bit about how we think through some of the complex situations and how best we can plan for them. So we know in routine communication 101 what families want. They want the three buckets. They want truthful, accurate information. They want emotional support, including an apology when it's appropriate. They want follow-up. They don't want to be abandoned. And as we've learned a lot from Kel Hemmergarn and other patient advocates, they may also even want to be involved in the quality improvements in terms of going forward to prevent similar such episodes from happening again. What we've discovered in doing our training and working with hundreds of hospitals now around the country, there are a variety of challenging conversations. There are the ones that involve complex personal or family dynamics. There's a big bunch of cases that center around the hearing impaired, various language barriers, and then finally some of the ethnic, racial, and cultural sensitivity that needs to be applied in some of these circumstances. And we're going to address all of these, again, with video as we go forward. One of the things that we've learned a lot in terms of planning to have these types of conversations where we need to communicate about unexpected harm events, the power of the huddle has been supremely important. And when we talk about huddle, it's getting the groups of people together, the stakeholders together, to talk about various questions to be able to try to deliver to the patients and or their loved ones those three domains: the accurate information, the emotional first aid, and the follow-up. And so those are the things that we want to focus on. And today, I wanted to share with you, these are a set of questions that we, again, have used in training with hundreds of hospitals, where we put these questions out for people to consider before, again, going in and having the conversation. Some of the important ones that are in here, I've highlighted in red, specifically some of the challenging ones about asking before we go in there whether there's any special personal or family dynamics or disabilities, language issues, or what have you to ponder before you go in and have that conversation. The other one that we have found super helpful is having people in these huddles consider the question, do you need to provide a shot across the bow? Which is, instead of just blurting out what you're thinking, kind of leaning in and mentioning to the family, you know, what I have to tell you may be very unsettling. It may be very difficult to hear as you begin to lean in and share with them some of this difficult information. And again, you can see these various questions as they come up that we think are really, really important to think about. You know, the sixth one down as well, who should be present, I think is really important. Again, when we think about the challenging conversations. So we're going to jump in right now to one of these kinds of scenarios. And again, the plan will be, I'll give you a few of the facts, we'll pull up the questions, you can kind of think about it. And then I have video of these various scenarios that we can play, and then we can debrief, we can talk a little bit about it. And again, Steve, I would encourage you or Pauline or others in your office to speak up, but also to encourage people to go into the chat. So this first case involves a child that has a history of psychiatric trouble, developed a seizure disorder, got admitted to an acute care hospital, got treated with anti-seizure medication, was stabilized, and then was transferred back to a psych facility. Medication reconciliation was done, and that's where mistakes were made, in that the child the handoff was for half the dose of the anti-seizure medication he should have received. And several days later, he's brought back to the acute care hospital having seizures. And the setting for this conversation is going to be in the emergency department. The parents, they're divorced. They're sitting in a room away from the child, waiting to speak with the practitioners. The father is the only parent who is present during the past admission and transfer. The room is very tense, and the father is the one that has sole custody related to issues that the child's mother had encountered that also involved legal issues. And so again, you want to think about right now, when you have this kind of dynamic, what are some of those things that you want to be prepared for? Is it going to change, you know, who you have come in the room and have this conversation? So I'm just going to play this brief video clip here. So you.
This is Kim. It was really hard to hear. You could tell by the nonverbal cues that it was very tense, but as the actual words that were said, I was having difficulty.
Oh, okay. Steve, how about you? Were you able to hear?
It was a little garbled, Tim. We could hear the provider pretty well, but not the patients.
Oh, okay.
We couldn't hear the provider at all.
Right, I agree.
Hey, Tim, I wonder, I'm sorry.
Yeah,
Good. I was wondering, you know, I agree. I couldn't hear that well, but I do wonder, had you known about the custodial relationship going in, would you have had the discussion just with the father?
Well, so good question. And what happened was, and that is probably one of the biggest points of the video that you can see, is they actually did not address that issue at all before they went in and they did this. And one of the biggest lessons learned was when you have this custodial issue, how to plan and prepare ahead of time. And as it turns out, in this is a real case reenacted. As it turns out, the father was willing to have the mother there, but what they hadn't addressed is what would the issues be with ongoing communication. So again, it gets back to one of those issues where you really need to think about it and really need to plan it when you have situations like that. So great question, and that is one of the things that from the planning standpoint should be talked about ahead of time. So the other things to think about it that they did really well was to focus on the child. When they started getting to the big argument, is bringing it back to that. It is important, just like Kim mentioned, to be proactively understanding what the parenting status is. and how critically important that is. And again, be prepared for conflict. The other piece that is really important is to consider the seating arrangement in the room. This worked out well because you could see the social worker was between the mom and the dad, and you had the provider off to the right, which actually turned out to be really, really nicely done. We've done this scenario before, and it turned really bad when it was all men in the room except for the mother, and the way that the positioning was set up, she really felt ganged up on. And so that was just another one of the issues that we thought would be, really important to consider in going forward and looking at this. So, and then the other piece that we want you to identify is when you know the room is going to be tense, who are some of those persons that may be able to be really good at de-escalation. Any other comments? Are you seeing anything in the chat out there, Steve, at all? Any other comments?
Yes, Tim, they were asking maybe if you could reiterate what the parents were saying.
So basically what the parents said is when the doc offered to share all the follow-up information of the review and what they learned and what they were going to do to improve, he had initially mentioned he'd share it with both of them, and the father stepped up and said, absolutely not. I don't want you sharing that information with her. And then they get into a fight over who's going to get that information. So that's the, and so then they, as you can see, they separated them a bit, went back to focusing on the child, and then offered to find a way to come to a resolution where they could keep both parents involved with the child's care, but also meet the concerns that the dad had. Anything else out there, Steve?
No, that's it. Thanks, Tim.
Great. All righty. So we'll move to the next one. So this is a situation where you have a full cardiac arrest that is completely unexpected when a major dialysis catheter gets pulled out of a patient. And the patient was ready to be discharged the next day. And you now need to have an immediate conversation with this family that has no idea anything went wrong. And one of the family members is deaf. And again, this is going to be a very high stakes conversation. And now you've thrown in one of the more complex situations, which again, having to manage and deal with a family member who is deaf. And so again, you go back to the power of the huddle. One of the big questions that you have to think about here is are there any special, dynamics or disabilities? In this case, you have a family member who's deaf. You do not have available to you in the hospital at this time somebody who is able to sign for that particular family member. And so you're going to see they have to use Marty. They have to use the technology as the means to communicate to the deaf family member. And when you see the video, when I bring that up, what you really need to focus on, okay. So if no other questions or comments, the thing dealing with deaf patients, it's really, really important that you understand what the level of their hearing impairment is. Those who are hard of hearing and can use sign language, but also spoken language as well. There are those who can use speech and lip reading, but the very deaf, in general in this country, they do use American Sign Language. And they may or may not use certain kinds of spoken language before. And one of the things I learned the most in working with these workshops around the hearing impaired is how for the deaf, the capital D, it is a whole culture difference than those of us who are able to hear. And it is their identity. And you can imagine for the deaf person in that scenario, how excluded they probably felt only having that machine to be useful for them to be able to be engaged in the conversation at all. And here is one of the critical diagrams that I learned that until I really started getting involved with these kinds of CRP cases did not fully understand. And that is the use of a certified deaf interpreter, again, which we did not have in this case. What we had in this case is you have the hearing person who is the doc explaining what's going on to the other family members who hear. And then you have, as you move to your left, the interpreter who is on the machine, the Marty machine, communicating directly to the deaf person. And in a lot of places, in really high stakes conversations, it is recommended that you insert a certified deaf interpreter in between the interpreter and the deaf person. These certified deaf interpreters are deaf themselves, but who really, really understand sign language, but they also understand the culture that the deaf person is living in and can really help them relate to what it is that's going on medically. And is super invaluable. Then again, when you just use an interpreter, may not be that particularly skilled, used on Marty, in terms of really understanding the life of the deaf person to whom they're communicating. So this is one of the, probably the really important features that I took away and have taken away from these circumstances. And so some of the lessons learned include really understand your resources in advance. That seating position could have been completely different to where they could have pulled the deaf person more into the middle of this. And you really do need to have that one person focusing on the hearing impaired, and as Kim mentioned, waiting to make sure that they have comprehended the information. And of course, doing that, you need to be prepared for some interruption to the flow. And if possible, again, recommending the use of a CDI. Any questions from anybody related to that, or Steve or Paulina, in terms of wanting to make sure that's as clear as possible?
I have a real quick question, Tim, just around resources. We have enough, we certainly have enough issues, unfortunately, in my jurisdiction, getting interpreters. So the CDI is news to me. I appreciate your points, but is that a national resource by chance?
Well, so there is, and almost every community has access to CDIs, and what some people are doing is, because you can't have these around all the time, what they do is when they know when they have advance warning that there is going to be one of these really difficult conversations, then they have found it worth their while to expend the resources to get a CDI. And what we're doing, working with some of the systems we're working with, is to find out in their community where they can get a CDI and really engage them early on. So when you really do need them, they know what it is that you're trying to move forward on.
Just one other thing. It's really important in these situations to only have one person talk at a time. So when the family was reacting and the doctor was trying to manage them and all of that, really hard for the interpreter to express to the deaf person who's talking when 4 different people are talking at once.
I completely agree, which again is why the planning is so important. And you need, the whole group needs to huddle up. And you kind of, Katie, need to set the ground rules before you begin having the conversation because of this added need. And keep that in mind when we get into these two other really, really critical scenarios. Really great point. Any other comments before we move on? Anything in the chat, Steve or Paulina?
No, that's all we have so far.
Okay, so now
I'm
we'll
going to mute everyone again, Tim.
Okay, great. So now we're going to move into another situation, and this is one where you want to focus on, sort of the nonverbal. Apologize ahead of time if hearing profanity is troublesome. Then I would recommend during this next enactment that you mute. You go ahead and mute it, but you'll still be able to see a bit of what's going on, and we can get into this. But this is a situation where a former employee in the hospital falls at home and breaks his hip and needs to have his hip replaced. And he's as sick as can be guy with congenital or congestive heart failure and other comorbidities. And unfortunately, post-op, after he's being fed, he decompensates. He has a respiratory arrest. They call a code. He gets reintubated. He gets a tension pneumothorax with a cardiac arrest, and he passes away shortly thereafter. The family agrees to an autopsy, and the autopsy shows it's one of these really unfortunate events, but there's nothing that anybody saw that was of concern to them about appropriate care not being delivered. The feeling was it was appropriate care. It's just one of those common tragic situations where you need to reach out to the family, explain to them everything you know, and love them through it. What the volunteer communicators don't know, and you'll see them surprised with this, is that due to a communication glitch, the home was called 3 times asking for this patient to be brought back to the clinic, not knowing that he had died before discharge from the hospital. And so you're going to want to look at the gentleman standing up and his face and the nonverbal cues he is just throwing out there. And it's interesting, when we've done this enactment, sometimes it takes many, many, many minutes for this to be discovered. In this case, although I edited the video, they did pick up on this fairly quickly. And again, so this is one of those ones where it's nonverbal cues, and you just need to be prepared almost for anything as it goes forward. So again, any other comments from folks looking at this particular enactment? All right, so moving to the lessons learned on this one is of course, be mindful of nonverbal cues. I agree with the comment that the seating arrangement is critical. It's also important that you meet with the interpreter in advance and you practice. And there are 3 kinds of interpretation. One is the consecutive, which is where you have to say something for a brief period of time, and then you have the interpreter speak, and then you go back and you start speaking again, and then you pause again, and that's sort of it happens sort of linearly. There are those who are able to do what's called whisper interpretation, and we used to use those occasionally where we knew it was going to be a really difficult or complex or highly emotional one, where the interpreter literally sits to the side and whispers into the ear of in this case, the Spanish-speaking family member, and literally is doing it contemporaneously. So there is no need to pause, when one is doing that. And again, so this is one of the ones you need to think about in your organization. How are you going to, again, manage, these sorts of situations? And then some people will say, though, if you're doing it consecutive, is you can use the time when the interpreter is speaking to observe the impact on all the family members, including the one where English is not their chosen language, and you can begin to ponder the communication strategy in terms of doing that. Any other thoughts, Steve, you or Paulina have on your end, or any of the others who are on the webinar, about lessons you've learned, using various interpreters, or anything in the chat?
There was a note here about the person who was pacing probably should have had a chair available to him if he wanted to sit down, and that having chairs in a circle might be helpful also. What are your thoughts on that?
I completely agree, Steve, which is why the seating arrangement is that situation. Now, I will tell you, had they asked him that, the actor would have responded saying, "I prefer to stand." Now, if he does that, that's a cue that it might be, useful to have just a side conversation with and say, "You seem pretty upset. I want to make sure that, we deal with your questions and we understand what's going on," and maybe able to do that. Any other comments or thoughts from folks about this particular enactment?
Tim, Steve, I had one other question. Just as we take nonverbal cues from ourselves, is there any time that the interpreter's nonverbal cues could play a role in this at all?
You mean that you're watching the interpreter and you're understanding something from them, or that the interpreter is picking up something who can then communicate it back to you?
Well, both actually. So is it the interpreter's job to communicate those nonverbal cues, and on the other hand, what would happen if the interpreter somehow is communicating a nonverbal cue without knowing it?
Right. So that's a really good question, Steve, and we're really going to get into the next scenario, but I'll try to explain it now. There are multiple kinds of interpreters, but if you are an interpreter like the woman in this video, Steve, her official job is an interpreter. And in their official job description, they are really only supposed to interpret. They're not to deal with other perhaps sensitive issues, other things that are going on. They have a job, and their job is to interpret what's being said in English into, in this case, Spanish, and Spanish back to English. Now that's different if you have an interpreter in your organization who, say, is a staff member who's gone through your competency testing in the organization to then be able to interpret in these circumstances. And so, Steve, hold your hat on that. You're going to see that in a very important way in the next enactment that we're going to do. But so, does that make sense? In other words, there's at least two types of interpreters, and you really are not supposed to expect official interpreters to do what it is you were mentioning.
Thank you.
Okay. Any other questions from folks out there, or comments from anybody? All right. So I'm going to go to this next case, which involves an insulin overdose that results in temporary significant harm, but again, no permanent harm. And it's got a really, really important twist in it. So due to a communication mix-up, a patient gets 100 units of insulin instead of 10. The patient is found on a med-surg floor, unresponsive, with a blood sugar of 35. He gets resuscitated, transferred to the ICU. He is stabilized overnight and then is transferred back to the floor. His preferred language is Somali. We did this particular enactment up in a part of Minnesota where, in this particular hospital, half of the patients are born to Somali moms. And so with this population, there's some really, really important things to begin to think about. And so now the job is you need to communicate with this patient and his friend about the insulin overdose. And in this case, Steve, you have an interpreter who's a staff member who works in the clinics and in the community, who's going to be there in the room. But again, think about all the things we've been talking about where people should be seating and the other parts there. But you really want to think about, for a while, in this case, that second from the bottom question, which is, what questions do you anticipate getting from the family? I can tell you the question that gets asked in the little scenario I'm giving you was a shocker to me, and I'd say pretty much everybody in the room. But then when we did the debrief, it was not such a big surprise, but boy, did it teach me a lot about some of these complex situations that we can get into. So okay, so let me share some of these slides with you. One of the things we've learned when we really did a deep dive on the Somali culture, particularly for those who have recently come to this country, the issues surrounding illegal organ harvest are incredible. And in fact, both the interpreter as well as this other person who is playing the role of the patient with the insulin overdose talked about how they all knew somebody who had a family member who either sold their kidney or had one of these other horrible things happen. And it was absolutely a shock to all of us in the room, but it was eye-opening to really kind of drive home to us how sometimes culturally incompetent, we can be when we get into some of these kinds of situations. And so it was really, really wonderful, enlightening to speak to these folks afterwards. The debrief is as fantastic as it is the 12 minutes of the full, disclosure conversation that they did. And it raised so many issues. In this particular organization, they plan to do an entire 8-hour deep dive with all of the various cultures that they have in their organization to make sure they've done what they can, they've done their due diligence to really understand how complex it is. And again, it was super eye-opening. And so some of the lessons learned, do include that it's really important to learn your language and cultural needs of your patients, including nonverbal opportunities, and identify your culturally competent resources. And in this case, Steve, this is what you brought up about official interpreters versus staff who've been deemed competent. It really was good for them to have taken advantage of this staff who's deemed competent. But the audience all agreed it would have been better for that interpreter to have gone in and talked to that patient and really find out how they're doing and who they would want to hear from within the organization. Did you see anything unusual, Steve, in terms of the people who volunteered to go talk to this Somali patient versus what some other opportunities are or were or could have been?
Yeah, well, we've got some comments here. I'd like to.
Good.
Yeah. So, one of the comments was that seating's important. They like the interpreter being in sight line, as in left of the hospital spokesperson, and they agree that being closer to the family, as if they're in support, resolving the language barrier for the family. And also, there's a comment about that it's important to have the background info because not everyone would feel confronting their provider, about a particular concern like this.
Right.
There's another comment about the role of women is important, with the woman being an interpreter. I don't know if you have any comments about that, Tim, at all.
Oh, yeah. So, Steve, I actually have, so this couple, the man and the woman, gave a beautiful description of Somali culture and what's appropriate and what is not. And this issue did come up about using female versus male. And for them, having her be the interpreter was completely appropriate. But it absolutely is something that you need to think about are the various gender roles that different people would play. Really awesome comment. And they also talked about, and this is the nonverbal opportunities, and I learned this, when I worked in the Middle East for 3 years, is that as a man, to not extend my hand to a member of the Muslim community who's a woman, and to wait for them to extend their hand, and then only then to shake it. And so I completely agree when you have this sort of situation, how good it is to have a very big debrief around what are these cultures issues, what do you need to think about, what are the gender issues and some of the others. Did anybody else comment, Steve, on the volunteers and how they may have been perceived by the patient?
We didn't have a comment on that. Do you want to elaborate what you're thinking?
Well, so, I mean, it came out and it was just a good conversation, sending 2 senior white people in to have a conversation with somebody who spent most of their life in Somalia may not be the ideal who to have go in there and have the conversation in order to be able to maintain trust. So one of the suggestions that came up from both of the colleagues from Somalia who were there would be, it would have been much more effective to have had a Somali pastor come in with perhaps the doc who was going to explain what the mistake was. And that being mindful of that as well can really help improve the likelihood of success in these kind of conversations. So Steve, that's kind of what I was kind of going at to see that. Where if anything, there is a big power gradient with these big leaders coming in and the patient being there already worried about what's happened and being surprised. Again, having the Somali pastor there would have been a much better use of the who, and again, these are the kind of things why they want to do a full 8-hour workshop is, all right, how do we think about this in our organization? How do we make sure that we have access to the right people, to come in and have this conversation? Does that make sense, Steve? Yeah.
Yeah, it does. I wanted to touch on your getting help from community members in terms of the process of doing that, and do you try to involve your PFACs and things like that?
Absolutely. So the goal here is, and what we're seeing more and more in terms of success at CRP rollout is the more engaged your patient and family advisory council is on quality and safety. There's now a couple studies have been done showing how much that impacts on safety, but also how much it really helps with the rollout of CRPs. And so that is absolutely, so when you build your PFAC, you want to make sure you have broad representation on it so you've got your community well represented. So really good question, Steve.
There's a comment here about the role of pastoral care and ethics departments in this, and that their experience has been that they've been very good with helping them understand the cultural differences and discussing things in advance.
I completely agree. And in fact, in many hospitals and systems, pastoral care is a fundamental part of two groups. One is the communication consult service, but the other is the providing peer support and emotional first aid to staff, because they, especially when you have a very diverse staff, the staff are going to have different needs. And so I'm so glad they put that comment up, and it is becoming what I'm seeing more and more of a best practice out there. Great comment.
Hey, Tim, what do you do if the best speaker to represent the organization may not be the one who is the most knowledgeable person involved in the case?
Well, so we would use them a couple ways. I think, and this is part of building the team, they make great coaches, Steve. So what you do is you get these really, really great communicators to coach the people that really need to be in there that the family expects to see. And occasionally, if you've got a bigger group, you can have those people join where they're helping with the communication, but you still have the content expert there to be able to do that. But we love to use them as coaches, for the others who need to go in and have the conversations.
Thank you.
Are we ready to jump to the last one?
Yeah.
This is going to be really quick. This is, what do you say or do when the recorder comes out and people want to record the conversation? So I won't go through the details of this case because we don't have a lot of time, but this is the fifth conversation you've had with the family, and you're now getting ready to move into the financial resolution phase, and the family has brought their lawyer to this conversation. And the question you need to think about ahead of time is, what do we do when somebody asks to record this?
They're not recording it.
Are you okay with it?
I am okay with it because I think this is your opportunity to learn from them about what they have to say.
Yeah, well, we trust you.
Okay, yeah, whatever you think.
Okay.
All right.
Great. Thank you.
Okay, so you can look and see, Steve, if there's any chat comments or anybody wants to say anything here in the last minute. What I did want to share with you is the system that is really building out their CRP is taking, we have dozens and dozens and dozens of various kinds of video scenarios that they have found super useful, and these are getting built into their library of resources. This particular video will deal with the resource on what are ways that you can respond when people want to record conversations and you're not comfortable doing it. So this is just, you know, one example of that. But any chat questions, any final comments, Steve, as we run out of time here?
No comments on the chat right now.
Okay. Any other final comments from
there is one right now. So they appreciated that the hospital worker reiterated that the family could come back as many times as necessary.
That's right. That's right. And that they're trying to address what the family's concern is that maybe this is the last conversation, so maybe they'd like to record it. And I like the way that they did that. The guy who said that, the guy in the middle is actually chief legal counsel for their system, and is fully engrossed and enveloped, you know, into their CRP implementation process. So anyway, you know, Steve, as I mentioned, we've got dozens of these various, you know, complex situations, and glad we could share a few of them today.
Great. Well, Tim, thank you very much for presenting, and thank you all for attending today. We are going to be posting these webinars on the Collaborative's website so that when you go back to your institutions and organizations, if people weren't able to attend, then you know, they're welcome to come in here. We're also going to follow this up with a white paper, a little issue brief around the subject as well. So thank you all very much, and we appreciate you being here. And that ends today's webinar.
Thanks everybody for attending and for your thoughtful questions.